I get a lot of messages from people who are struggling with chronic pain and wondering whether or not they should have surgery to try and resolve their condition. Oftentimes these messages are accompanied by imaging studies and radiology reports and people who are desperately seeking answers and trying like heck to avoid surgical intervention. And what they usually want to know is, based on what I see on their imaging studies or read in their reports, should they have surgery? And I almost always find myself beginning my reply to these folks in the exact same way, and that's by letting them know you are not your MRI, you're not your CT scan, and you're not your X-rays. You see, as great as those things are, and they're fantastic tools, they've come a really long way in just the time that I've been in practice since 2006, but still, they have their limitations. And one of the things that imaging cannot tell us is how a person who is in pain is going to respond to conservative treatment and rehabilitation. In order to assess that, you need to look at how the person who's standing in front of you moves and functions. But rather than just talking about this, I want to show you what a functional examination in a person who's considering surgery for chronic pain actually looks like. So recently, a patient came to see me. He's a young guy, he's only in his mid-30s, and he's been suffering with chronic upper back pain here for the past 5 years. The pain can reach a 10 out of 10 in intensity, and sometimes it gets so bad that it actually gives him a stomach ache and makes him nauseous. Now, in his words, he's been to more practitioners than he can count since this problem started, and no one has been able to help him. During one visit to his doctor, he was given an MRI, which showed that he has 2 herniated discs in the base of his neck. In light of those findings, it was recommended that he have surgery to correct his problem. And when he came here, what he wanted to know was if there was anything that he could do short of having surgery that could help him to recover his functionality and eliminate his pain. Okay, so a couple of things to look at here. Number one, the left shoulder, you can see, is internally rotated significantly. We're looking at knuckles straight on, and we have shoulder elevation on the left side. Go ahead and rotate that way, your whole body. And then you can see the forward head position here with the ear pushed way out in front of the acromion. And then go ahead and look up at the ceiling for me. So we should have 60 degrees there, you guys, and we are looking at number 1, wincing, which is abnormal, and number 2, 10 degrees of motion, all at the upper cervical. There's nothing happening at the lower cervical spine whatsoever. Just rotate as far as you can over your right shoulder and over the left shoulder. So significant restricted motion over the right. One more time over the right. So approximately 15 to 20 degrees short of the left. Come back to straight. Now I'm going to have you tilt as far as you can to the right. Pain with that? Mm-hmm. Looks like it, yeah. And the other side? No pain there.
No.
Let me see the left one more time. So left is damn near normal. Maybe 5 degrees short. Tilt the other way. Nothing. Yeah, maybe a quarter of the normal motion. Right off the bat, you can see a pretty significant postural dysfunction with both internally rotated shoulders and a forward head position. But we also saw extremely limited range of motion with 2 movements in particular, and those were right lateral flexion and cervical extension. Not only was he lacking 75 to 80% of the motion that he should have in those 2 directions, but they actually triggered his pain. Which is great for us because it allows us to go through our exam and retest those super painful motions and see if it's possible to introduce things that will nudge him in a positive direction that would show up as increased range of motion and less pain. So for example, here, what I'm going to do is put him in a non-weight bearing position and retest that painful right side bend. Did you see what happened there? As soon as we get this patient into a non-weight bearing position where he's lying down flat on his back, and we have him reattempt his most painful range of motion, which is right lateral flexion, his range of motion tripled and his pain levels dropped off to almost nothing. You could see how comfortable his face was and how willing he was to keep pushing further and further and further into what was previously a super painful range of motion for him. Why did this happen? because when he's lying down on his back, he has external support from the table and gravity is pulling him down into that support. And so we know, based on this finding, that there is a strong instability component to his pain syndrome, and in order to resolve his problem, we are going to need to add stability to the system. One other thing that we saw when he was standing was internal rotation of the shoulders, and so we'll take this opportunity when he's lying on his back to open those shoulders up and see if that improves his range of motion. He was real tight in the pec minor, so pec major here, he does great. But as soon as I get him into this higher angle, it's super restricted. So what we're gonna do is get in here with a percussion tool right on his pec minor. There we go. Feel that just let go. So we just got about 10 degrees there on that second drop. I'm gonna lower your headpiece 1 notch. Does that activate your pain?
No.
You saw me gently lower the headpiece there and ask him about his pain. And the reason that I did that is because the first time I had Ty lie down on his back with the table in a neutral position, that is with the headpiece in line with the rest of the table, it immediately triggered severe pain for him. And in order to eliminate that pain, I had to elevate the headpiece to a 20-degree up angle to push his head forward enough to compensate for his forward head position. And so I used that dropping the headpiece back as a way of assessing whether or not we had made progress. So it's obvious that his body responds favorably to opening up the pec minor and reducing the amount of protraction at his shoulders. Now what we'll do is we'll follow it up with an active exercise that he can easily reproduce on his own at home, and we'll see what kind of results we get. As you roll the band back, your head wants to poke forward. I want you to fight that feeling. Stay really tall as you do it. That's what I want to see. Does that create any pain?
No.
Perfect. Give me 5 more just like that. Perfect. So immediately I'll just have you bring those bands around, set them down on the table there, and then let me have you face me straight on, and we'll go back into that right neck side bend. Ah, unprompted. Did you see the eyebrows raise? He surprised even himself. And now, like I was talking about before, we're gonna work on adding stability to the system. And for that, we're gonna use an exercise called chin tucks, but we're gonna be doing it in its most regressed form, putting him in a non-weight bearing position where he feels safe and comfortable, and most importantly, doesn't experience any pain. Start of our session today, Ty was experiencing what he called clamping, which was the onset of his pain while being in a neutral head position where the headpiece is in line with the rest of the table. You can see here that his chin is elevated above his forehead, and that is a classic sign of upper cervical hyperextension that goes with a posture prolapse syndrome. Now, when he keeps the back of the top portion of his head in contact with the table and retracts his chin, go ahead and pull that down, Ty. There you go. So we're getting activation of the deep neck flexors. You can see that the top of his head kind of gets taller on the table there. So we're elongating the spine, and the clamping and pain for Ty go away in this position. So this is fantastic. Like I just explained to him off camera, we are using his responses from the examination to custom build his home routine. We just did 2 rounds of chin tucks, and now let's retest right side bend. Right side bend looks 100% normal, and we get a laugh out of Ty, which that was his most painful position. Let's get you to turn sideways, and we'll get a look. So we already see a slight retraction of the ear over the shoulder, and now let's get you to look up at the ceiling. So 50 degrees where we started off at 10. Any pain there, Ty?
1 or 2.
Awesome. Come on back. Guys, I want to make it absolutely clear here that I am not against surgery. There are absolutely instances where it is the best and most appropriate option for a person. What I am against, however, is making that recommendation based solely on diagnostic imaging without even conducting a functional exam to determine whether or not that patient is a good candidate for basic rehabilitation, which is less invasive, less dangerous, less expensive, and yields a far better outcome in most instances than surgery ever could. If you enjoy this style of video and you want to see more functional examinations on real people, leave me a comment down below. And if you'd like to learn about one of the most common contributors that I find among the people who come to see me complaining about chronic lower back pain, check out this video. Beyond that, I just want to thank you so much for watching. Make sure to hit the thumbs up button and the subscribe button before you head out of here, and I'll see you next time.